Thank you so much, Mrs. Eastman, for introducing me. Thank you so much to New Testament Church of God for inviting me. And yeah, let's have a chat. We can, you can have your tea, your coffee, your water, whatever it is, and we'll talk about the menopause today. I mean, we're a small select group, so I've got a limited view because I've got the slides up, but if you could like raise your hand, do that hand emoji, I might be able to see that. Or if Mrs. Eastman, could you just like, you can stop me and say somebody's got their hand up and they want to ask a question or something like that. So it's always a pleasure to be with you. I'm Dr. Joan St. John. I've worked in Brent area for decades and I love it. As Mrs. Eastman said, my specialist subject is diabetes. I'm not going to be focusing on diabetes today. We're going to be talking about the menopause, so something slightly different, but let's see if I can not mention diabetes for the hour. I don't think I'll be able to, but let's see how we get on. So what I propose to, I knew this was going to happen. Sometimes I have to stop sharing. Bear with me again. Okay, so hopefully I can get this to work. Oh, there we go. So what I proposed to talk about today was the menopause, obviously. And does it matter? If it matters, what you can do about it, point you in the directions of some resources, and obviously take questions. Now, we can do questions at the end. If you've got questions that arise during the talk, then, as I said, just please put your hand up and we can do that. So my first question to you, as I say, because I'd like it to be interactive, please, but I think we're small enough to do that, is what is the menopause? Who would like to answer it?
The menopause is when women, our bodies start to change. And okay. Yeah, when our bodies start to change, go into another trimester.
Okay, so can I unpick some of that? So sure. It is called the change because our bodies do change. The trimester that you mentioned is more associated with pregnancy. So you can break pregnancy down into 3 trimesters. That's where the tri bit comes from. So it's the change in our bodies, and that can be due to hormone changes. And essentially, it is when your periods stop. Now, how can you know that your periods have stopped? If you think about it, as you just said, is it Merlin?
No, it's Angela.
Angela, sorry. So okay. Angela, how can you know that your periods have absolutely stopped?
Well, you start getting the signs of irregular periods, and then you get times when you don't have a period and the stop-start thing.
Yeah, absolutely. So thank you very much for that. So Angela, as you said, you quite rightly said, it's when your periods stop, but you may not know that your periods have actually stopped, because in that change, which sometimes we refer to the menopause as the change, you can get irregular periods. So you might get more frequent periods. So some women get periods every 2 weeks. You might get a longer gap between your periods. So you might be starting to get periods every 3 months. And this is what we call the perimenopause, or sometimes called the climacteric. So you may see those terms, or you may hear those terms. And you can only actually diagnose the menopause when you look back. So when you've not had a period for a year, that's how you make the diagnosis. But it is a retrospective diagnosis. So when you've not had a period for a year, you can look back and say, okay, you're now in the menopause. But remember, if you've got slightly irregular periods, it can be difficult to make that diagnosis, but you can make the diagnosis of the climacteric or the perimenopause depending on your age. So the mean age is 51 years old. But do you know what the age range is for a normal menopause?
Do you mean when it starts?
So what ages can it start from and to that it would be normal? So I've given you a clue there because I've said the mean age is 51.
Yeah, it's up. So go ahead.
30.
30. Is that Barbara?
Yeah.
Okay. Anybody else?
I probably would have said about 45.
45. Okay. So we've
I'd
got
say
30, we've got 45.
I'd say 50.
I'd say
But
45 to 50.
45 to 50. We're
Say
almost
48.
there.
48.
48. Okay.
I would
So,
say, can I say 45 to 55?
oh, who's that?
Charmaine.
Charmaine. Spot on. Spot on. So, you know, none of us are the same, are we? We're all different. And the age range for a normal menopause is 45 to 55 with an average age of about 51. Okay. So, oh, what's happened? I want to highlight something to you, a study from the US. It looked at diverse communities and it found that in Black women, we tend to have the menopause slightly earlier. That perimenopause that we spoke about, that change time, can go on for longer. And guess what? Our symptoms are more severe. I mean, you know, it's not fair, is it? We start periods earlier as Black women, we tend to, and yet when we come to the other end now, the menopause, we're getting more severe symptoms, more hot flushes and more night sweats. So when we talk about the menopause, we have to talk about the perimenopause, we have to talk about the menopause, and then we have to talk about after menopause. So, and then other thing to bear in mind is early menopause or premature ovarian insufficiency. And I'll explain a little bit about that later on. So Charmaine got it spot on. 45 to 55 is the age range in which we would consider that's the normal age for menopause. So early menopause, as you might gather, is below that age. And if somebody is starting to show the symptoms and the signs of the menopause before 45, then we have to look at why that might be occurring. And that's when we're getting into the realms of the early menopause or the premature ovarian insufficiency. So as we've said, it's 12 months after your last period, but you've got to look back before you know that you've gone 12 months after a period. Just want to highlight that there isn't a specific blood test for the diagnosis of the menopause. Does that surprise anybody?
I thought there was, to be honest. I thought there was a
Yep.
specific blood test for the menopause.
Yep. And it is the case that there isn't. Now, in certain circumstances, so if you're in that 40 to 45 year range, if you are having certain hormone treatments, so it might be like contraception, certain contraception, whereby you don't have any periods, and we're trying to establish if you're in the menopause, then we can use a blood test called the FSH. It's the proper name for it is the follicle stimulating hormone. It's a hormone that affects the brain to help you to produce hormones, and that becomes raised because your body is not producing hormones, which is the estrogen, as it used to. And so that FSH, that stimulating hormone, which is trying to get your body to produce the estrogen, actually becomes raised. Now, again, you're using it only in certain circumstances. So for the vast majority of women, you're going to make the diagnosis of menopause on the basis of timing, so 12 months since the last period, your age, so 45 to 55 age group, and the symptoms. And we'll go on to talk about the symptoms in a minute. But I just want to highlight that, you know, this menopause, this change, this time in your life is an opportunity for health promotion. We've got different times in our life when we can be really healthy or examine our health. So sometimes in pregnancy, you can like re-examine your health and what's going on with it. Menopause actually could be another time for you to use it as an opportunity to think about your health and to re-examine that. So things like your lifestyle, so things like exercise, your contraception, you need to re-examine that. And some people may be surprised to hear that, because some people are thinking, do I need contraception at that time? We can talk about that a bit more. Your family history, so your health in the context of your family. What are you at risk of? Here we go, diabetes. So is there diabetes in your family? Is there heart disease in your family? Is there high cholesterol in your family? Those are the things that are now going to become more important as you go forwards, and you'll become what we call postmenopausal. Have you got existing conditions? Are you living with things like high blood pressure? What about previous treatments? Have you had treatments for life-threatening conditions? So have you had cancer, those sorts of conditions? Have you had treatment for it? And what are your wishes? What do you want out of your life going forward? How would you like your life to be? How would you like your health to be? So, you know, it's an opportunity for not only you to examine your health, but also your healthcare practitioner to examine your health along with you. Any comments, any questions? Okay, so I'm going to ask you now, oops, no, what are the symptoms? What are the symptoms of the menopause?
Sorry.
Sorry, go on, Teresa.
Yes, sorry, before you move on, you know, when you talked about no blood tests, etc., when they do, I was like 46 when I started, and they did actually do a blood test. So I'm just wondering, what do they still use the FSH after the 45 period?
Well, the current recommended advice for us as healthcare professionals is that we don't use it once the person is within that age group. However, a lot of us healthcare professionals still do use it. But what I have to say to you is, remember we were saying about the change, and I think it was Angela that was saying about the irregular periods. So those irregular periods are like a manifestation, like a sort of mirror shined on what's happening with your hormones. So if your hormones are up and down, erratic, all over the place in this change time, this perimenopausal time, then sometimes the FSH will be raised, sometimes the FSH will be within normal. So that's why it's recommended that you don't, as a healthcare professional, use it to diagnose every woman as having the menopause, because you're going to get it wrong. Because in that perimenopause time, which can last for years, the FSH can be up and down and all over the place, and you can't say categorically, this is the menopause or it's not.
Okay.
So that's why.
Okay, and then you went on to about lifestyles, the health, and I know you didn't want to mention diabetes, but hopefully you will actually include that in there, because it does affect everything, as you said.
It does. But you see, that my problem is if I start talking diabetes, I won't stop talking diabetes. So I'm trying my best. I'm keeping on track today. I'm talking about the menopause, but of course, we'll talk about other conditions.
Yeah, thank
you.
So
the other thing I would say to you, Teresa, is that in terms of the blood tests, now the FSH we've talked about, yeah, but sometimes you have to do a blood test to exclude other issues. So if somebody's getting hot flushes, you can sometimes get similar symptoms if your thyroid is not working properly. I mean, you won't get all the other symptoms, but you know, sometimes you have to look for other conditions. So I'm not saying you can never have a blood test at this time. What I'm saying is that you can't use the FSH categorically to diagnose the menopause if the woman is within those ages. It's not recommended.
And could I just, you don't have to answer this now because it might come up later. We talked about when it normally starts, but the ending can be anytime. Is that correct?
Yeah, we'll come to that. We'll come to that. Yeah.
Bye-bye.
So I'm going to ask now the symptoms. I'm sure there's some women here, if you don't mind sharing with us what symptoms you had as a result of the menopause, or the change, let's call it that, because the perimenopause, that lead up to the menopause, is going to give you symptoms as well. You can put it in the chat or say it. What's the biggie that loads of people get?
My worst ones were
Yeah,
night
hot
sweats.
Flushes.
Yeah,
Hot flushes, I heard.
yeah, yeah,
Night sweat.
Night sweats were the
sweats.
worst. Yeah.
Yeah.
Okay.
Low mood.
Low mood,
vaginal dryness.
vaginal dryness.
Mind bog or clog or whatever you want to call it.
Yeah,
Just can't remember things.
yeah. You got pretty much most of them. So again, here we go. We've got, as I said to you, more of those hot flushes. So if you're talking about Black women versus white women, I should say white women versus African American women, because this was studies done in the States, then the white women were getting the hot flushes for about 6.5 years, whereas for African American women, it was about 10 years. We mentioned hot flushes, we mentioned night sweats, we mentioned the vaginal dryness. What's the other issue that you can get with the vaginal dryness is that whereas when the vaginal tissues are healthy, have those hormones going through them and everything, and the pelvic floor muscles are as they used to be, then you don't tend to get problems like urine infections, thrush, itching. But when you have vaginal dryness or the muscles aren't as strong as they used to be, then unfortunately it can predispose you to things like the thrush, infections of the urinary tract as well. So quite commonly women after the menopause can get things like urine infections. We've mentioned that brain fog, loss of concentration, the low mood was mentioned, but sometimes it can be like elated mood. All of a sudden, like you're, feeling fantastic. And then you sort of plummet down and feeling low mood. I saw this funny cartoon when I was doing the research for the talk. And it's a man and a woman, and he says, "I thought you were in a good mood." And she says, "Well, that was half an hour ago." So, sometimes those moods are just like up and down, and it's a bit like the hormones, up and down. Your libido, so your sex drive can change again because of the change in the hormones, and things like sleep disturbance and things like headaches, muscle joint pains, because it seems that estrogen has anti-inflammatory actions. And so when you're getting this relative lack of estrogen hormone, it can affect your muscles. And one of the other interesting things I found was that it said that people can be sometimes diagnosed with fibromyalgia because of these aches and pains that they're getting, but actually it may be just the lack of estrogen that's causing the aches and pains. And then fatigue, so that energy that you may have had previously changes as well.
Definitely.
Can I just ask Dr. St. John?
Sure.
Some of these symptoms that you've mentioned are almost similar, apart from the hot flushes. They're similar to when you're having a period, a normal cycle.
Yeah,
Like,
because
for example,
yeah, because if you imagine that you've got rise and fall of different hormones throughout that approximately month that you get your cycle, your menstrual cycle, and it replicates some of that. It's a bit like when you're pregnant, it's like full on because you've got like massive amounts of these hormones. It's almost like the reverse of that, because these hormones are now much less, and so you get all the reverse of the symptoms that you sometimes get in pregnancy. But pregnancy, menstrual cycle, menopause, it's the effect of the hormones and the different levels of hormones that are causing some of these symptoms that you're getting. Well, most of the symptoms that you get.
We've got a question in the chat, and I've also got a question for you.
Okay, thank you.
The question in the chat asks, why is it that these symptoms are prolonged for so long for people from Black backgrounds?
You know, I mean, here we go with diabetes. You know, why are people from Black African Caribbean heritage more likely to develop or more at risk of developing type 2 diabetes, high blood pressure, menopause symptoms? If we had the answer to that, we would have the answer to a lot of health issues. And I think, it's a huge question, because yes, if we had the answer to that, we'd be able to tackle a lot of health issues. Is there the will to look for the answers to those questions? Are we involved in the studies to try and answer those questions? There are many aspects to that question. And I don't know if in my lifetime we're going to know the answer to it, but it would be fantastic if we did, in so many respects. So the question is usually broken down to, is there some genetic issue, or it is environment? So is it something within our race? Difficult to imagine that, because if we think about race, I'm really going off track now, is a social construct, okay? Because genetically we are more similar than dissimilar from any race. All races are genetically more similar than they are dissimilar. So it's hard to think it would be genetic, but there may be some genetics that we don't know about yet. But then we've also got the environment. How does the environment affect our health? Stress, food we eat, air we breathe, you know, all of those things. So I apologize for going off track, but it's an observation that we suffer these symptoms for longer. We have them more severely. The answer to why is huge, and I can't give you a simple answer to that.
And someone else asked if the symptoms are prolonged for longer than 15 years, if that's dangerous. And I wanted to ask about hot flushes. I don't understand hot flushes, so I just wanted to ask, but will you know that you're having hot flushes if it's a case that you're more hot than normal? It feels like you're in the Caribbean every day.
I wish.
Or what? You know, how do you know?
Well, okay, so not everybody has them. I said it's the vast majority of people who have them. Sorry, before I answer your question, Barbara, what was just remind me what the first question was.
The other one was if the symptoms are prolonged for more than 15 years.
Yeah, so if the symptoms are prolonged for more than 15 years, it's not dangerous, but it's pretty miserable. I knew of, and I'm talking about in the context of my work, people where it went on indefinitely. You know, women and I don't want to make anybody feel low in mood, went on for decades with them, and they had lots of tests to make sure that there wasn't any other issue. And it's very infrequent for that to happen, but sometimes it does happen. It actually goes on for a lot longer, because remember, what we're talking about here is averages. So there'll be some people who don't even know they've gone through the menopause. The only thing they realize is that they've stopped having their periods, and they don't have any of these other symptoms. And then there are some women who suffer terribly with the symptoms. So Barbara, it seems in terms of the hormones, not only the hormones like estrogen and progesterone, but also the stimulating hormone, that FSH, and there's another one called luteinizing hormone. They have an effect on the brain. The brain, as well as lots of other functions, has what we call a thermoregulatory function. So to regulate your temperatures, like, you know, the thermostat on your boiler. And it seems as though the change in the hormone has an effect on the changes in your thermostat. So your thermostat becomes reset with the menopause. If I can share with you, I don't mind sharing with you, with me, the first thing I realized was it was like a heat in the middle of my shoulder blades. And it's like, what? It was a bit weird, lasting a few seconds, maybe a minute, but sometimes it can feel much longer than that, much more severe than that. I'm just giving you my experience, but each woman is going to experience it slightly differently. And then it changed. So I would have actually feelings of heat in my upper body, and it's almost like rising from your chest up to your head. Now, some women will visibly sweat. I didn't visibly sweat, but I would just get this intense heat. I wish it felt like being in the Caribbean every day. It would be fantastic, but it wasn't like that. It was just like this intense heat, like, you know, and you've probably seen women who just think like, I've got to take layers off because I just feel suddenly exceptionally hot. But as suddenly it goes. So for each and every woman is going to be different, but I'm just sharing with you the way it was with me. Yeah.
Thank you.
So how to stay healthy. Really important to look after your bones. And how do you think you might do that?
Through exercise.
Yeah, certainly through exercise, but specific sort of exercise. So what we call weight bearing exercise. So on your feet. So you need to be doing something on your feet. So if you're walking, things like badminton, things that you're used to doing. If you want to do something more intense, slowly start, slowly build it up. But it's what we call weight bearing exercise. The other thing, which is important.
Vitamin D.
Vitamin
D.
D, thank you so much. It was just what I was just about to say, and the calcium as well.
Calcium.
So really important. Yeah, those two things, really important now in this phase of your life, that you make sure you have adequate calcium and adequate vitamin D as well. When I said being active, I don't just mean being physically active, but also being socially active, because you are going to have lots of challenges at this time of your life, aren't you? We were speaking earlier about the challenge of the different age groups that you're looking after. We tend to be the carers. Now, we were carers for our children. They may now be becoming more independent, but then we have our elderly relatives which we're looking after as well, and sometimes you're looking after both. So making sure you have that support. It may be of your sisters, and I mean sisters in the widest sense. It may be of your partner, it may be of your community, it may be of your church. You know, just making sure you have that support. Be active and make sure you do things for yourself. Now, with the hormone changes, the way we gain weight is going to change. So it's going to be slightly easier to gain weight, sorry to say, in the menopause. But also where it goes changes, and you may have realized that already. So it's more likely and easier to gain weight around the middle. So here comes the diabetes bit again. So if you're gaining weight around the middle, that is going to put you more at risk of developing type 2 diabetes. If you're at risk already because you're a Black woman, if there's some family history of type 2 diabetes, gaining weight is going to increase that risk further. Trying to keep a positive mind with all those challenges, with these hot flushes and these sweats going on, and your sleep disturbed, and caring for different age groups, and trying to hold a job, and you know, all of those things. Try to keep a positive mind, because the hormone changes are going to affect your mood, they're going to affect your concentration, they're going to affect, you know, how you feel about yourself. So trying to keep that positive mind. And sleep is so important. I think we underestimate how important sleep is. So wherever possible, try and make sure that you get your adequate sleep. I can see there's numbers just going up in the chat, and I'm not sure if there are questions there. So if there's questions that you want me to address now, just highlight it to me.
Some of them are just comments. The questions, I'll let you know.
Okay, great.
Or
Thank
let
you.
know.
Okay. So remember I said at the beginning about contraception, because I think a lot of women get caught out, and actually this is one of the most common times for unplanned pregnancies. Because remember, you've got irregular periods. So you may have gone a few months now without a period, and then you're thinking, okay, it's fine, I'm safe, I don't need to use that contraception that I was using before. But just to point out that because of those irregular periods, irregular hormones, you can potentially be fertile for about 2 years, even after your last period, if you're younger than the age of 50, but a year if you're over the age of 50. And I just want to highlight that because a lot of women get caught out. But after 55, it's highly unlikely because we've got a limited number of eggs that can be fertilized. So after 55, it's highly unlikely that you can become pregnant and you can stop contraception then. So if we talk about treatment for the menopause, I'm aware that in terms of time, we've got about 20 minutes or so. So I can talk about treatments, but I'm not going to be talking about specifics. I'll talk in general. Or we can maybe open up to questions. Just give me an idea.
Can I just interrupt? Teresa had the hand raised, I think. Teresa?
Oh, it's okay. You've now gone on to it. I was just going to ask, I know you're not going to be able to say specific treatments, but I just wanted to say about HRT. Is it good, bad? Just summary, because I know it's a big topic and it's really general.
Yeah, it's a huge topic. And I have to keep it general because, you know, I mean, if we all put our cameras on, we can see we're all different. Each of our circumstances are going to be different. So things like family history, you know, previous conditions and so on, all conditions that we're living with are going to be different. So I would always urge you to go and speak with your healthcare provider for your individual circumstances about what's going to be best for you. But I'm just going to say that there's different types of HRT. So remember, I've mentioned those two major hormones for us as women, estrogen and progesterone, but we also produce some testosterone as well. And sometimes testosterone is one of the hormone treatments that can be used as a hormone replacement therapy. It's used in circumstances where women's libido is less, and sometimes it's used to treat that. Now, I put under this as well, remember, mood can be a major issue. So cognitive behavioral therapy, which is a talking therapy, it's not a hormone replacement therapy, is one of the treatments that can be used in the menopause, and something called SSRIs, which are antidepressants, but because of the change of hormones, because it can affect the way the brain functions, sometimes if women aren't best suited for estrogen and progesterone or testosterone, then sometimes the SSRIs are used to treat some of the symptoms of the menopause. So there's a variety of treatments available for menopause treatment.
Teresa, can I just ask, all the ones you've listed, is there anyone less harmful than the other, or they are all the same kind of thing?
I think, Teresa, what I would say again is for you as an individual, it's going to be which one is going to be best for you, which one is going to suit you best, because for you, it may not be the same as it is for me. So globally or generally, I can't say to you, this one is better, that one is not. But I will tell a little bit about the preparations. And when you think about hormone replacement therapy, it's been around for about 50 years. So knowledge has increased over those 50 years about being able to tailor it better to what a woman requires. So if we look at the benefits, because there's some benefits of giving hormone replacement therapy, it's thought that the change in estrogen levels can affect your risk of what we call cardiovascular conditions. So things like heart attacks, strokes, that sort of issue. I'm sure people would have heard about osteoporosis, which is in simple terms, thinning of the bones, and that puts you at risk of having things like fractures. So HRT definitely can reduce your risk of having things like what we call fragility fractures. So fractures that occur because you've sort of toppled over. And it can, of course, give symptom relief. So all those symptoms that we talked about, so the hot flushes, the vaginal dryness, the brain fog, perhaps not absolutely certain with that, but it can give relief from those symptoms. And you've got to always weigh up positives and negatives of any treatment, you know, whether it's paracetamol or any other treatment that you're using. So what are the negative effects? Some increased breast cancer risk, some increased risk of venous thrombosis, which is like DVT, and that's increased if you've got a family history or if you're overweight or obese, and some small increase risk of stroke as well. So here, one of the things I want to highlight is that in terms of the DVT or the venous thromboembolism risk, if you're having an oral preparation, the risk is slightly greater than it is for a transdermal, the patch preparation. So that I can certainly say to you, the transdermal, the patch, tends to be less associated with risk of venous thrombosis than the tablets. And with heart disease, there is some increased risk around the time of the menopause. And if you have estrogen alone, then there's no increased risk, but there is some slight increased risk if you have estrogen and progesterone. Now, you may need to have estrogen and progesterone if you're still having periods. So if you're going through the change, you're still having periods, even albeit irregularly, then you will need to have estrogen and progesterone in some form or fashion. If you have had a hysterectomy for whatever reason, then you only need the estrogen. And there isn't any increased risk of things like stroke associated with having just HRT, which is just estrogen. But remember, as an individual, you're going to have an individual risk. You're going to get individual benefits from HRT if you choose to use it. So that's something you have to discuss with your healthcare provider. So people are always very concerned and very worried about the risk of HRT and breast cancer. And breast cancer, I think many years ago, I came to one of the health days and spoke about breast cancer. The lifetime risk for a woman is about 1 in 8. So you can see that we've got a really significant risk of breast cancer. And if you have HRT, which is estrogen alone, if you can do, then there's little or no increased risk of breast cancer. But if you have to have what we call combined, the estrogen and progesterone, then that can sometimes slightly increase your risk. The risk depends on how long you use it for. The risk can depend on what age you were when you started it, and then also your background risk of breast cancer. So it's a bit of a busy slide, but I don't know if you can see can you see the cursor? Can you see me? Yeah?
Yeah.
So let's look at the breast cancer risk. Okay, if you've never used HRT and you're using a combined estrogen and progesterone HRT, then there is let's call it a background risk of 13 women out of 1,000 women to develop breast cancer. Now, if you use HRT, estrogen and progesterone, for 5 years, there will be an extra 8 women out of 1,000, so 21 women out of 1,000 who will develop breast cancer. So that's 13 if you've not used HRT, 13 out of 1,000 versus 21 out of 1,000 if you do use HRT. Okay. And going forwards, because remember I said to you that we've got this very high lifetime risk. So beyond that use of 5 years use of HRT, up to the age of 69, if you've never used HRT, sorry, I lost my cursor. If you've never used HRT, then 63 out of 1,000 women, when you're talking about up to the age of 69, can develop breast cancer, and an extra 17, so that's 80 women out of 1,000, because they used HRT for 5 years, could develop breast cancer. So you can see that there's some increased risk, and you have to weigh up whether you feel this is a risk worth taking or not. But there's definitely an increased risk, and it shows there the increased risk for things like, if you look down here, for venous thromboembolism, so things like the DVT, and for ovarian cancer as well. So I think we've probably dealt with that.
We've got some questions. Joan, I don't know if you want to deal with the questions, or shall I go ahead?
Should we deal with them? Because I'm conscious of time.
So one asks, what other supplements are good for menopause? Another one, will having a hysterectomy cause the menopause? And the other one asks, what foods and diets make the menopause worse?
Worse. Okay. All right. Shall I deal with that one first? So supplements, foods, and
Hysterectomy.
hysterectomy. Thank you. Okay. So how best to do it? Okay. Foods. So if you think about the foods that you eat that might make you feel a bit hot anyway, what foods would you eat that make you feel hot?
Sugars, carbohydrates.
Okay.
Spices.
I missed that.
Sugars, carbohydrates.
Okay. And Mrs. Eastman, I missed what you said.
And spicy food.
Spicy foods, curry. Yeah. So things, pepper, things that make you feel hot anyway tend to make the symptoms worse. Okay, it's not going to work for everybody, because you know, people can eat peppers, you know, like varying degrees, and some people won't even feel anything, and some people will like break out into a sweat. So I mean, it is said, and I mean, this isn't going to be culturally specific, but it is said that spicy foods tend to make the symptoms worse, or can make the symptoms worse. In terms of supplements, you have to look at the whole health. So remember, we said your bone health is really important. So taking things like calcium and vitamin D is really important. Now, you may actually not need as much iron as you did previously, because you're not losing iron through the blood loss that you had with you when you're having your periods. And some of us women can really lose a lot of iron because we bleed very heavily. But you should have a good mineral and vitamin intake, but the ones to concentrate on are the calcium and the vitamin D going forwards. And a hysterectomy, it can sometimes, with some women, precipitate the symptoms of a menopause, but unless you have your ovaries removed at the same time, that may not be as acute as it is if you have your uterus and your ovaries removed, because your body is able to manufacture these hormones, the estrogen and progesterone, yes, mainly from your uterus, yes, mainly from your ovaries, but from other organs within your body as well. So there will be still a small amount of circulating hormone, even if you have your uterus removed. But with some women, they're very sensitive to the hormone changes, and they may then experience the symptoms of the menopause very abruptly. Now, if HRT is not right for you, if it doesn't suit you, remember I said about the antidepressants, and it's basically this, I have to say it's off-label, so it's not licensed, but it is through trials being shown to help with things like the hot flushes. So there's different antidepressants which are used. There's something called clonidine, which was actually a treatment for blood pressure initially, but can definitely help with hot flushes. And that's something that I prescribe quite frequently for women who weren't able to take HRT, but were really troubled by the hot flushes. And then other treatments that can be used, again, off-label. So I think people would know about this herbal treatment coming from the primrose family. It's called black cohosh. There were a number of treatments around at various times which were thought to be helpful in terms of menopausal symptoms, in terms of, herbal treatments. So there is some evidence to show that it may be helpful, but the difficulty with getting the evidence, if I can backtrack a little bit, if you are doing a study to show that treatment X works, and if you can manufacture X, and every time you manufacture X, it's always the same concentration, the same level, then it's easy to show if it works or not. With a herbal treatment, if you're trying to gather that herbal treatment, you're not sure of the active ingredient within that herbal treatment, you can get various concentrations, you can get various levels, and then it becomes more difficult to show it definitely works. So they've done lots of studies to try and show that black cohosh works. Some do, some don't. So the jury's still out, but I know that some women will take this as a herbal treatment. And in terms of the positive results that it's shown that it does help in terms of things like the hot flushes. So, but it's not absolutely sure how it works. Make sure that you buy a registered product. So places like Holland and Barrett, places like Boots, you can get registered products from there. I'm always a bit wary about what you can get on the internet because you can never verify what you're getting. It's currently not advised that you take it for more than 6 to 12 months because, as I'll show you in a little while, there has been some associated adverse factors, infrequently, rarely, but in terms of the liver being affected by black cohosh. Yeah. So the dose recommended is 40 milligrams, but when you look at the packet, it says 6.5 milligrams, but that's the extract, and that is equivalent, as you can see from the slide. I can't see it properly on my screen, but it's somewhere between, I think, like about 20 and 50 milligrams. You see what I mean? In terms of a herbal treatment, you can't specify it's 40 milligrams, definitely, because herbal treatments don't work like that. So I said to you about the liver problems. Some women, again, because it can have a hormone effect, might get things like breast pain or breast enlargement or some spotting. But again, this is very low incidence. It doesn't happen frequently. But, with any treatment, and herbal treatments are treatments, you have to be aware of the positive, the negative effects, who it's best for and who it's not best for. So we talked about the perimenopause, early or premature menopause now. So 40 to 45 age group, you might be at risk of that if you've, excuse me, not had children. Seems to be more frequently if you've not had children or if you've had not many children. Smoking, there is a huge effect of smoking putting you at risk of having an early or premature menopause. And if you're underweight, so by that I mean that you're having a body mass index which is below the normal, so really underweight, then that can predispose you to early or premature menopause. And it's in these sorts of age groups that you'd be doing that FSH test. It's recommended that you do that FSH test. So if you're before the age of 40, your menopause can occur, but it is absolutely premature. It is absolutely something that you need to identify where possible, so by doing that blood test, and it is really recommended that you have some treatment for it. You can see at the bottom of the slide, the prevalence of that varies. Not many women will have this, but some women do. We don't always know why, and for most women who this occurs in, we don't know why, but for those that we can find a cause, sometimes it's genetic, sometimes it's because they're living with another condition, sometimes it's because they've had to have treatment for, let's say, a life-threatening condition as a child. That can sometimes predispose them to that. I'm conscious of time, so I'm just trying to rush through these last slides. The reason why I would say you really need to consider doing something about premature menopause, so that's before the age of 40, is because it can increase your risk of cardiovascular disease, osteoporosis, and in some reports, dementia as well. So it's really something to consider, having perhaps those hormones that your body lacks, because you've started to have the menopause at an early age. So just want to signpost you to some various resources, either information sheets, helpful websites, just giving lots of information there. And I was going to ask you this, but I think we'll have to leave that now for any other questions, because I've gone over time and I apologize.
Thank you very much, Dr. St. John. I know we've gone out over time, but if you just allow just a couple of more questions, I hope that's okay with yourself and with the others, just about a few more minutes. Is that okay? Right. I think there was...
Can I ask a quick question?
Yeah.
Because that screen went so quick, I was just about to take a picture of the useful resources. Are you going to send this to us, or can I see that list again? That's it. Lovely.
There you go.
If it's fine with our Dr. St. John, we will package the slides and we will share them on our church website, which is wntcg.org/events. But we will get those out. Check with whomever invited you today, and they will let you know how to get to the website.
So what I'll probably do is just do like a page or something with a couple of the slides. So certainly the resources, just highlight to me, ladies, and gentlemen, anything, other slides that you particularly wanted me to put on, and I can do that.
That's fine. Yeah, there's a couple more questions in the chat I think we need to go through, if that's okay, and then we'll sign off. Barbara, do you want to see the... Hang on a minute.
Yes. So someone shared that they used black Cohosh and it worked for them for about 2 years. Then it stopped working. So just as information there for everyone. And we had a question on what's your recommendation for hair loss or hair thinning. And yeah, the other bits were just, it's super informative, and can they see the slides for further reflection?
So in terms of black Cohosh, the recommended duration is between 6 and 12 months. I think with any treatment, there is a useful window in which you can use that treatment and it works for you. So thank you very much for sharing with us the time that it worked for you as an individual. It's helpful for other people to know that, but I'm going to say it again, everybody, we're all individuals, so you have to be sure about the information for you as an individual. And in terms of hair, yes, your hair, your skin, remember I was saying about the muscles, the pelvic floor muscles, but your general muscle strength, all of those things can change after the menopause because of the change of hormones. So I think a general widespread vitamin and mineral supplement is useful. You can actually get vitamin and mineral supplements for over 50s. So if you don't mind being labeled, then they tend to have things like iron, they tend to have things like calcium, they tend to have vitamin D, vitamin B12, which again will be useful for hair growth. All of those things are usually packaged in a easy to take away. Sometimes you can chew them, you can dissolve them, you can swallow them, you know, so yeah, there's lots of varieties. I wouldn't, I think a question popped up, which one would I recommend? I don't want to recommend a particular one because, you know, cost may be an issue for some people. The way you take the preparation may be an issue for some people. You have, I think on the whole, quite well-trained people in places like the health food shops. So if you go to one of the big health food shops, they will probably be able to give you more specific advice about the vitamins and minerals that they're carrying and which one might suit you best, and you know what might suit you, your pocket as well.
Thank you so much. Back to you, Joan.
Thank you. I think Dr. St. John deserves a round of applause from everybody. If we just unmute him and just give her a round of applause. Thank you very much. Thank you very much for that detailed information on menopause. And as I mentioned before, we all need this information as women, because at some point of our lives, we're going to have some of the experiences, if not one, but one or two, but at least we know where we stand and where we can get all the necessary sort of medication, not really medication, but supplements and things like that. But most of all is to make contact with our GP or speak with our GPs to sort of get the proper and the proper advice, really. So having said that, go ahead.
So I would say even wider than that, you know, because yes, GPs, I was one myself, retired now, but I also think sometimes it's the practice nurses who will be doing this aspect of care, and sometimes, you know, if it's all just not working for you, then we're very lucky at the moment to still have a menopause clinic. So there's a menopause clinic at Norfolk Park. Now, not everybody needs to go to the menopause clinic, but for some people who have particular circumstances, then, you know, it may be a referral to the menopause clinic.
Absolutely. One thing that came to mind was those who live in the Caribbean, you know, under that sort of intense heat. I wonder how they manage to sort of, you know, get to the heat, you know, having heat in their body already, and then, or, you know, having to sort of contend with the heat from the sun. It makes me wonder, and the mere fact that we have the additional resources of, you know, the various treatments, as well as you mentioned before, the menopausal clinic, you know, we're quite fortunate, to be honest.
It's not always the ambient temperature that affects you, though. So, you know, it can be winter, it can be cold, but your body thermostat is like on maximum. So you can still get the hot flushes, even though it's cold, you know, in the room that you're in or in the environment that you're in. For some people, the ambient temperature can make it worse, but for others, you know, your body's just doing its own thing anyway.
All right then. With that said, thank you very much, and I thank you all for those for you know, for attending and for sharing. We'll just end in a very brief prayer, and our closing prayer. Heavenly Father, as we come to the end of this session on discussing the menopause, we thank you, Heavenly Father, for what has been accomplished here this morning or today. We pray, Heavenly Father, that the topic discussed will help us to look after our health better. And as we depart, dear Lord, we ask that you'll be with us, you'll guide us and protect us and keep us in good health. For this we ask in Jesus' precious name. Amen.
Amen.